Hi, everyone. Welcome to today's webinar. There's still a whole bunch of people pouring in, so we're going to give it just a couple minutes to let the last few stragglers make their way to the webinar before we jump in. So maybe another 2 minutes and we will get started. All right, it looks like it's slow. It's like watching popcorn pop. You see the numbers keep going up and up and up, but we've slowed down. I think we've kind of maybe hit our max. So why don't we go ahead and get started? Thank you everybody for joining us today. This is our last webinar of the year here at PayerWatch. This is our little holiday gift to the team on writing effective appeals. So I want to thank everybody out there for joining us, spending some time on this Thursday afternoon with us. My name is Eric Christensen. I'm a vice president here at PayerWatch. So we're very glad to have everybody on board for today's webinar. A quick note on Ryan, if you want to move that slide forward to, if you can't hear us, I know there's always issues, but you can change your audio if you want to over on the right side or in your that little box there. You can change it to phone if you need to and dial in. If you do have any troubles, please drop something in the chat and let us know. We will address it as quickly as we possibly can. Make sure everybody is able to hear what's going on. Also, I want to just point out over in the handouts, there are some handouts there for you to download, so don't want you to miss that. Very good. Today we have Brian McGraw. He's the CEO here at PayerWatch, as well as Ryan O'Hara. He's the managing principal for Denial Research Group as our presenters. So I'm going to turn things over to them and just thank you again all for joining us today. Ryan?
Yeah, thanks, Eric. Are we required to read this disclaimer?
Oh, I'm sorry, that's on me, yes.
Okay, all right, just want to make sure.
I didn't want to dump that off on you, you're right. So just a quick disclaimer here that we are required to make sure we share with you all. So PayerWatch publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of the appeal community. PayerWatch does not certify the accuracy or authority of these materials. These materials are distributed and presented as research information to be used by healthcare providers in conjunction with other research deemed necessary in the exercise of healthcare providers' independent professional judgment. PayerWatch claims no liability in relation to reliance on the content of these materials. The views expressed in the materials are the views of the materials authors and do not necessarily represent the views of PayerWatch. Any references are provided for informational purposes only and do not constitute endorsement of any sources. There are no conflicts of interest to declare for any individual in a position to control the content of this presentation. All right, I think we're covered. Ryan, over to you.
All right, hopefully we can get more riveting than the disclaimer
Yes.
for the next 90 minutes or so. Thank you everyone for joining. I'm Ryan O'Hara, I'm the managing principal of the Denial Research Group. I think you're all literate, so you can read this. I've got a long background in revenue cycle operations and consulting and management, and have been the managing principal at DRG for the last 10 months or so. And just to familiarize yourself with DRG, we kind of stand at the forefront of this concept, emerging concept, I would say, of smart work queue and content-driven denial management. Using kind of machine learning, we really try to integrate continuously updated and meticulous content to kind of support smart work use. So think of the idea as queuing up work you can win and then giving you the content to win it. And that's a lot of what we're going to talk about today is what makes successful content. What are the things that I and our teams have learned over the last 20 plus years doing this that help us take the fight to insurance companies with a little more teeth and with a little more effectiveness. All right, so let me get back to this. All right, we can all see my screen. All right, I forgot everyone's muted, so we're going to take silence as a yes. So I'm going to spend quite a bit of time on this slide, a majority probably of my time on this slide, because I do think that one of the things that I find as I get boots on the ground with clients and prospects and hospitals and health systems is you have a lot of people who are working really, really hard. You have a lot of people that are absolutely committed to the mission of the facility and the communities that you serve. But the content lacks some of the teeth needed to make an argument and take that argument to whatever stage it requires to win it. So I'm going to hit on kind of 8 bullets here that we use pretty regularly in terms of making a solid legal argument. And so I'm going to start with this administrative clerical errors, substantial performance, non-material breach. What do I mean by that? So by the language of the law, a breach is considered material when it's so substantial and fundamental to defeat the object of the contract as a whole, right? So in other words, you're kind of going to the root of the contract. And conversely to that, you've got incidental breaches that really don't warrant things like enforcement of the contract or even termination of the contract. And so what I mean by that is you can make an argument, and there are CFRs, Code of Federal Regulations, as well as state legal statutes that help support these. And these need to be cited and referenced in terms of making this argument. And so that argument might look a little different in, let's say, Arizona, where I'm at, than it might look in Maryland, where Brian and Eric are at. But it's using that legal foundation to say you are in breach of contract, and here's why. And so language that I might typically use, now this will be state or federally regulated agnostic in the way I'm going to use it here, but we want to make sure that in your market and your region, we're using the argument that serves that best. But so in terms of this first one, language that I might use here is, when compared to the facility's overall substantial performance in complying with the payer's claim procedures and policy guidelines, this denial is incidental in terms of the entirety of the submitted claim package. I think you can use this for line item denials, right? To say, I met the burden of proof and this is not a material breach of the contract. Or I think you can use it actually in more aggregate claims data necessary as well to say, listen, we might get denied on 7% of our denials. We might get denied on 12% of our denials, whatever that number is. But the process is so onerous that clearly we are meeting the burden of proof on the majority of denials. Again, this can go macro or micro, line item or all aggregated claims. But the point is just to say that these deviations, whether again, line item on a claim or macro on all claims, are hardly considered material in nature, considering how much burden of proof I in fact actually meet. So it's using this, I am not in breach of the contract, clearly by the nature of my actions and your actions, I meet the burden of proof more often than not. And you're in fact kind of, you're not abiding by the law by unilaterally denying a claim based off non-material breach. So that's kind of this substantial performance non-material breach. The second one I want to kind of go through here is administrative clerical errors. And you're going to kind of see some themes developing here around clerical errors as well as the physician-patient relationship. And these can kind of be used across multiple arguments. But the point of an administrative clerical error is to say that both federally and states all have laws that speak to the No Surprises Act at this point, and they reject the notion that medically necessary services can be denied based solely on mere administrative mistakes or errors. Right, so what is the language that I might use to talk about here? It's basically to say that we, the facility, and our clinicians and their support team provided medically necessary services that were warranted due to the circumstances surrounded by this admission or this patient's continuum of care or this patient's condition. And retrospective authorization and payment are absolutely appropriate based on the clinical merits that we followed. Now, the next one I'm going to get into will kind of talk about a little bit of gray area that I think insurance companies use and that we can kind of use in there as well. But it is in a sense to say that you can't unilaterally deny, based on the No Surprises Act, our claim to be reimbursed based on, in this case, medically necessary renderance of care. The third one is this administrative clerical errors and out-of-network status. So a very, very similar argument, but out-of-network is not an insurance of non-payment. Out-of-network really can only apply to certain situations. It certainly doesn't apply to emergency care. And it kind of speaks to this argument that we, as a facility, are deserved by the law a fair reimbursement plan that establishes on the claim merit. You can't just flat out refuse to pay based on network status when medically necessary care was rendered. And again, think of the ED as probably the most common and easy example to think of this. But it's here is you're saying again that regardless of our network status, the law, both federally and at the state level, does say that when we provide medically necessary services, even inside the four walls of a non-network, non-contracted facility or hospital or health system, that we are owed appropriate reimbursement. Now, appropriate reimbursement is vague, but it's basically meant to say you can't just not pay us when we delivered care based on network status. The fourth one is physician-patient relationship. And this is a very broad argument that can be made inside the legal realm of things to say that the treating physician and the facility establish a relationship with any patient once they enter a facility, and that we should be using our reasonable degree of care and skill as a clinical care team to take care of any patient that presents. And then when we take what's called an affirmative act to diagnose and or treat a patient, we are in fact owed reimbursement or at least compliance from an insurance company as we deliver that care. And there's other federal regulations and state regulations that support this idea of a health delivery institution, a hospital or a health system in this case, owes its patients a duty of care, skill, and diligence used in administering that in the best way that they possibly can. And so it just gives the facility a platform to sit on and say, we abided by the law, we treated anything that might have been unforeseen or foreseen in the best way that we possibly could based on the information at our disposal. And some language, generic language that's used here is the physician and staff acted appropriately in accordance with their duty of care to treat the patient's condition. The facility and the care team acted appropriately and promptly with orderly care and diligence to mitigate the effects of deficient information, right? And so you're basically saying, based on the information I had, I treated the patient in the best way I could using common clinical practice. And an example of this, like one that you might see, is a patient comes in with chest pain. And of course, any clinical care team is going to make sure that they're ruling out a heart attack. And it may have ended up that the patient was not suffering a heart attack at all. And in fact, oftentimes that's not what was happening at all. But you as a payer, by the law, are not allowed to deny me for all of the diligence that I did to rule out, in fact, a heart attack. And so we may have ended up on a different diagnosis. And an insurance company may come back and say, the patient wasn't having a heart attack. Why were you treating a heart attack? And it's like, no, we weren't treating, we were diagnosing and following standard evidence-based models and practice of care to make sure that we got to the appropriate diagnosis. And when that diagnosis was in fact achieved, we cared for and provided the duty to that patient in the appropriate accordance with that diagnosis. But there is law and language out there in the law to protect you from this kind of thing. And so, like, language that we will often use here is the facility, in light of the corrective actions off of the initial diagnosis, follow the appropriate decision making, and you cannot reverse this payment based on the clinical merits of a physician and a patient arriving at an appropriate diagnosis through appropriate clinical measures. And Eric, if any questions, I know we're kind of waiting until the end, but if any questions that might pop up that you feel like I can quickly answer, feel free to let me know. Coding. So I often call coding the language of healthcare. And where we have seen this little to no explanation provided, and I'm sure all of you have seen this because it's exploded in the last 4 years, is on these 252s and 16 CARC responses, which is basically their way of saying, we want additional information. And they may supplement that with a RARC that might give you something to follow, but this has really, really exploded in the last probably 4 to 5 years of payers coming back and just saying, I'm going to 252 this and say I need additional information. Well, by failing to provide a reasonable and accurate explanation for why you're denying this and just saying I need more information and making me, the hospital or the health system, go on a very dark and winding journey to try to figure out, the law does support that you have to provide me with some sort of reason as to why you assigned this denial. And so language that I might commonly use here is, when denying claims, it is an unfair practice to fail to provide a prompt and reasonable, accurate explanation of the basis for such actions. Your denial letter lacks detailed explanation of why my assigned codes are incorrect, as well as the reasoning behind my assigned codes based on our own clinical validation, which of course a payer doesn't really have privy to. So again, you're making this argument of, you don't have the ability to just say I need more when you don't really make a case as to why you need more, and you are not a part of the patient-doctor relationship, patient-clinician relationship. And so there's various state law and federal law that says by not including that information, you violated that statute, and that the denial letter itself does not conform with the requirements set forth by the law. So this is, again, I see these all the time in that 252.16 realm of just, we want additional documentation, and the burden of proof to provide that documentation is on you. Promissory estoppel. This is basically an argument that says, when I render care, I have created a reliance on you, the insurance company, and the patient to render payment under a promise, right? And so this is commonly used in the pre-auth space. I have received a pre-auth. I've went out and I've done the arduous work to obtain pre-authorization for services that I'm going to render, and you have still, even after I did that, denied me. Now that denial can be based in fact on I actually performed the procedure that the pre-auth was, or based on, again, the best judgment of a clinical party, they did something different. Once they got into the procedure, got into the diagnostic or whatever, they said we need to do something slightly different based on what I'm getting back in terms of that diagnostic work or that more invasive work that a surgeon or someone like that might do. And so the argument language here is something like, you should have known that we would be relying on this promise, again, given the regulations that we're citing and referencing here, and that I rendered those services only after obtaining that authorization, and this denial breaks the claim of your enforceable promise, right? So it's to say, you are detrimentally hindering me on something that I thought I was going to be receiving as a result of delivering this clinical service. In this case, it's a payment. I expected to get paid. I got the authorization. You didn't do it. And here's the legal language that I'm going to be putting into here, both from a federal and or state level to support it. The second to last one here is unjust enrichment. The argument here is that the legal language here is that a party is unjustly enriched when a benefit is conferred upon the party by another, and that party retains the benefit without payment. So you are a payer in this case, and again, legal snippet, legal research to support this, to say you are being unjustly enriched by not reimbursing me for services that we obviously assumed were going to be paid. This could be, again, kind of that pre-auth, or it can be something else. It's to say that you are receiving an unjust enrichment by not benefiting me and by retaining that benefit. Again, in this case, it's money. And a big part of this argument is to say that a payer doesn't have the firsthand knowledge to challenge the determination of a clinical care team. In fact, the payer lacks the firsthand knowledge to challenge the determination that we should be enriched or paid for the services rendered. And so language, the kind of generic language here is you lack the knowledge, and then there's kind of a line that I think is effective to use here of, had the patient's treating physician or care team refused to provide these medical services, the payer would be responsible for arranging such service as well as paying for any costs that arise from complications due to delay. And so it's making this argument, again, that a care team was absolutely appropriate as long as the documentation supports it in the actions that were exhibited and the behavior that was exhibited in terms of treating this patient, in terms of that patient-physician relationship. And what now would have happened had we not rendered that care? And I think it's a really good argument to make, is if we had not rendered this care, what were the outcomes? What would the potential risks and potential more cost have been associated with this continuum of care? The last one I want to hit on is good faith and fair dealing, and this really goes to any contract. Like, it's not just between us and insurance companies, but good faith and fair dealing. There's legal language at the state and federal level that supports good faith and fair dealing with any contract. But it's basically the argument that I and we want to make here is that a payer has really failed to act in accordance with fairness and honesty by not considering the circumstances and supporting documentation surrounding this patient for the dates of services or continuum of care that we may have provided here. So one, we know that the law imposes an implied covenant of good faith and fair dealing on any contract, insurance and hospital or anything else outside of the healthcare sector. And the argument that we're trying to make here is that you, in fact, are not acting in good faith and fair dealing, and here's the legal argument I'm going to make to support that. And so language that I might use here is the payer has a responsibility to act reasonably when investigating claims and can only, in fact, deny claims after a reasonable investigation discovers the true facts to support the denial. And so you basically say this denial, in fact, breaches our contractual obligation of good faith and fair dealing because you really didn't do the research. You don't understand what happened in the circumstances and supporting document involved in the patient-physician or physician-client patient relationship. And so you are, in fact, again, we will argue breaking the law by not administering this contract in good faith and fair dealing. So that is, in a very quick way, a way to just kind of use legal language, use the statutes at your disposal. Real quickly, I want to go through, is using their language against them. And this is taken from an excerpt. I practice what I preach. This is an excerpt that I use in a personal case of somebody very, very close to me. But it's when I did the research of their summary plan description and their own policy, and I talked to their folks, they said, no, we review this every year. Well, I would argue then that you haven't reviewed it every year because there's substantial medical evidence supporting long-term efficacy of this treatment or drug in this case with this diagnosis, and you haven't seemingly updated your policy in 4 years. And so the second snippet, the second bullet you'll see is your criteria for this, as stated in your policy, was last updated in 2020. You've also told me that you update your policy every year. Well, clearly you're not, because you have not updated this one since 2020. And here's the legal and clinical research that supports an argument from last year that says you are out of practice and your medical practices are not the most current and accepted of the industry and of the clinical science that supports the treatment of this diagnosis. And then that last bullet is just a way to, again, kind of say, if our patient is going to suffer adverse health consequences here, we will take this to the NCQA. We will take it to your state Department of Insurance, and we will talk about your failure to adhere to the most standards of practice that exist right now. So understanding their policy, using their policy against them is incredibly effective. We got this one overturned fairly easily. There was some time involved, but it was to just say you're lying kind of about your own policies. Quickly, I'm going to this is an example of an appeal letter. And the reason I've cut off the second page is I can't really fit 6 pages of this, but I want you to see that what we have here is 5 pages of evidence-based guidelines and practice. You have to make the argument as to why we're following science and why we're following the law, and you got to reference it and you got to cite it. And so it's to say that I'm going to source this document and I'm going to take it to the highest level. And one of the things Brian and I talk about a lot is this is the language that will win this thing. Now, maybe it won't win it at first try because insurance company makes the rules and adheres to the rules. But it is to say that if this continues to escalate and we follow that escalation process and we don't give up on it, any reasonable administrative law judge or person who's interpreting this is going to say, yeah, I think the hospital deserves to be reimbursed for this. What's your argument? We didn't want to pay? Oh, well, they're making a clinically researched and referenced and legally researched and referenced argument. You're just saying I don't want to because it behooves you to hold on to that reimbursement and be unjustly enriched. Okay, so real quickly, I want to go through just the concept of denial prevention. I'm a huge proponent in the idea that you can't just perpetually fight denials, especially with the trends going on in the industry. I often cite in presentations I do a study from 2022 that shows that denials have went from 8.3% to 13% in the last 5 years. I think that's all payers, by the way, and I think you can argue that commercial is outpacing 13% denials. And I think certainly with some of the information that's been coming out with the recent United Healthcare news, that's north of 20% in many instances that people are citing. But we can't just continue to fight denials. We have to get upstream. We have to do this. And so real quickly, I just want to show a couple of things that I think are important in terms of setting up a denial mitigation or denial prevention department. And it helps you make the financial case to whoever your decision makers are to say, this is behavior that we have to invest in because we can't continue with the same or less staff and resources that we used to have to fight what is now a 50% increase in denials over the last five years, which may even be very, very different in your own facilities, your own markets, where it may even be worse than that. And what we're really, really talking about here is commercial behavior. And so understanding the root cause of the volume by the payer is really, really important to start this. These are some examples of some reasons, denial reasons based on by payer, by cases. I would argue that you want this by dollars as well, because it'll help you make the most informed decision of where to point your efforts and your resources. And if you can, I would do it on net reimbursement as opposed to just gross charges, because reimbursement is honestly what matters more than gross charges. So this is an example of just some data that says, here's the way some payers are behaving related to some of our top internal codes for denials. You can do this off of the CARCs and RARCs if you want to, but you can use your internal payer adjustment codes and those kind of things inside your specific EMR as well. This is an example of a baseline. It's to say that we know what payers are doing, we know what they've selected, we know what we're winning, we know what we're losing, we know what we're writing off. But the goal of setting a baseline is to get to something that looks a little bit more like this, that becomes an improvement dashboard, a way to both internally say our efforts are worth the squeeze, as well as a way to promote back to those people that entrusted you with the decision to invest in denials prevention, to say, we're having an impact, here's where we're having an impact, here's the financial impact, and we are seeing a decrease in denials, specific especially to the stuff that we're kind of targeting. And you can't target everything, you just can't. But a very, very simple method that I have used very successfully in the past is the idea of in-flight and a parking lot. And the idea could be, we have identified 80, maybe more, 80 really, really problem denials based on payer and diagnosis combinations. I've even, in my past, went down to the attending level, on the attending physician level from time to time, to just say, I think I've got a problem with the documentation of this particular attending or this particular specialist, and we've got to figure out a way to close that loop and make sure that they become the kind of documenter and quality doctor that we know in fact they are. But the idea of a parking lot is to say, I've got all this stuff that I know I could be working on, and I think that can be overwhelming. And the idea of in-flight is to say, we're working on these 3 to 5 to 8 things right now. And those are the things that we're going to focus on. And the other 72 to 75 to 77 things are important, but we can't do them right now because we've got to focus on these high priority issues. And that goes to the kind of the concept of governance and how you set up these things. This is not an end-all be-all. I'm just going to tell you it's something that has worked for me, and the players that I have found are very, very important to have at the table. Is if you have it, project management. If you don't, it's not a killer, but you do have to have access to the data. And I think what project management really does is just give the organization and give the group task management, prioritization, and organizations to say, what are we working on? And let's stay focused on that. To me, the best PMs I've ever worked with are the people that honestly are a bit of a pain in my butt because they hold me accountable. I need that. I think we all need that from time to time to say, someone is making sure that we are pointing the right direction and we are on task here. And that's where I think a great PM or a great project management structure can help. Business intelligence, whatever you might call it within your department, but whoever it is that's responsible, maybe in your department or at a more macro level for measurement, the ability to kind of set up those dashboards and maintain those dashboards that we looked at on the previous pages. They're meant to help you say what goes in the parking lot and what should be prioritized. And the governance of this structure determines that and makes sure that the constituency is built to manage that. Obviously, revenue cycle operations, I think it's important that all members of revenue cycle have stake. It's a bit of blood sport, and I think it's one of the things that has infuriated me about RCM in the past, as someone who's overseen large institutions from a revenue cycle management standpoint, is I don't buy into this idea that the back points fingers at the front, that access points fingers, like, until we all understand and build constituency of we're in this together, and it's a very, very convoluted, complex process, and we need to have all parties involved so that we understand the perspectives of everyone. The example I often use is billers love to point fingers at patient access, but they don't understand the job in a lot of ways. They don't understand that. Let's use the ED as an example. You got people in there that are sometimes trying to give you erroneous information. It's high paced, it's fast paced, it's hard to get information. And it's not that you're not trying to do your job, it's just, it's difficult. It's fast paced, there's lots of moving parts, and it's very, very easy to make mistakes inside revenue cycle operations. So from an RCM standpoint, you want all parties included, and the focus there is we want to build process improvement. We want to get upstream, and we want to fix the things that are causing these denials to show up. Clinical leadership, you have, like, I was just having this conversation yesterday. It surprises me that there are still hospitals and health systems out there that tell their revenue cycle people, do not bother the doctors. And I agree that you should not bother them for the purpose of bothering them, but you have to bother them when it comes to the quality of your institution, which, oh, by the way, also equals predictive reimbursement. So I often say that coding is not about reimbursement, it's the foundation for every quality. And coding is also the language that helps get us paid. So if we focus on quality, reimbursement kind of becomes an outcome instead of this goal that we chase. But clinical buy-in and quality improvement, I think, are the angles that good clinical leadership bring to this governance structure, is to say, we are focused on quality, and when we get good quality, reimbursement becomes easier. And I can spread that message to my contemporaries on the clinical side of the house. IT and clinical informatics, in terms of EMR support, you will ultimately come across things as you are researching and doing account reviews and figuring out why this particular diagnosis with this particular payer continues to be a denial problem for us, that the EMR could help support. Whether that's just through easier documentation or things like templates or whatever it is to help our clinicians get to the outcome that we all want, but in the most non-onerous way possible. So EMR support is key, of saying, we found something that continues to be the trigger as to why we don't meet the burden of proof for payers and why they continue to deny us. And we can fix this inside the EMR and make our clinicians' jobs easier. Finance, in terms of just validation, you've got to be able to make the dollars and cents argument as to why your investment is working or not working, is working in certain areas, is not working in different areas. But again, I think we owe it as good stewards of our employers to say, I'm going to validate, I'm going to put my skin in the game and say, when we work on denials prevention, it actually helps us downstream as well as upstream. We're fixing problems and we're seeing less problems in the long run. And then I think managed care is really, really important. And I know Brian is particularly passionate about the role that managed care, and I'm sure he'll talk about that in his section coming up here in just a second. But a good managed care department has to have awareness of what is going on in terms of those payers. And they have to close that loop in terms of rules and contractual terms. A lot of managed care departments focus on rates. And I will stand on the highest pulpit I can and say rates don't really matter that much anymore. Rates are typically mandated inside of the contract to not exceed a certain amount anyways. You can't go like, but what they do, insurance companies being they in this sense, is they have ambiguous terms that allow them to act in ways that both set the rules and make the rules on the fly and enforce those rules in a way that they want to. And those are the kind of things that I think have led to where we're at more than rates. Rates are I mean, I've done so many different studies that said a 5% rate increase really resulted in 0.3, in 1.2, and actually negative because it was strategic in a way that said we don't get rates here, but we do get rates here, and the aggregate of that was 5%, but we in fact lost net revenue on the book of business. And I think bringing managed care in so that they understand the process loops that we have to jump through every day, that our clinicians have to jump through, that our RCM operations folks have to jump through, certainly would help bring some visibility into why this relationship is not even close to on level ground. All right, so those were just kind of things I want to talk to you about making successful arguments. I'm going to hand this off to Brian and let him go as well. And I think I did that.
Great. Hey, thanks, Ryan. And I have to tell you, what a great job. Really. You continue to impress. There's no doubt about it. Okay, like Ryan, everybody can read the screen. I've been privileged to serve with hospitals and health systems for about 20 to 25 years. Just really focused on putting some software, some processes, some methodologies together that we always talk about this level the playing field. So I'm privileged to serve the communities across the nation where we serve well over 600 hospitals, and those hospitals are serving their communities willingly and fighting hard to get it. Not muted, and I can move it forward. So Ryan mentioned earlier payer content, and it is something really important to all of us. And what payer content means is really gathering all the information that we find necessary to do the most effective job of pursuing, being persistent and persevering through both not only clinical arguments, but legal arguments as well. I also want to make sure we put out there, our next webinar is going to be January 15th. There is a pre-registration located at the end of the session. You'll get access to that, but it's a joint roundtable discussion between PayerWatch and our ADAM experts, the Association for Healthcare Denial and Appeal Management. So I'm just putting this out there so you can set that aside. I'd be terrible CEO if I didn't at least give myself or our company and the staff that work for us and serve all these hospitals a shout out. So my 30-second pitch is we really pioneered audit management and denial management back in the early 2000s. Veracity is probably the most robust and comprehensive denial, audit, and appeal management software. Appeal masters, we have nurses and physicians and coders and CDI experts, again, that have been providing services to those hospitals that need them in a just-in-time basis. And so we're not big believers in taking all of your outsourced material. We think we'd rather provide you education, training, and tools so that you can do it internally yourselves. And it would be terrible if I didn't shout out Ryan's new group, really, that focuses on assessing what's wrong in organizations, quickly analyzing and how we can help them improve through some denial audit management reengineering. So thank you, Ryan, and your team. ADAM is an important part of who we are and what we do. So we've been gathering payer content and good legal argument and clinical standards of care for the last 15 years. And now we're giving it back to the community. So we think it's important that you have access to a lot of these tools. And so, Adam, there's a paid portion and an unpaid, but we certainly urge you to go take a look at the association and see if it's for you. We started in COVID in 2020. It's grown now to be almost 800 full-time appeal professional members, and mainly the folks that are on this call, clearly clinically driven, and some technical folks are on the call, but mostly clinically driven. And so we're trying to make sure that we also draw in revenue cycle professionals to understand, hey, there's tools and tips and tricks here that we can use. If anybody's ever seen me present before, this is one I typically present every couple of years. And it's that your firm resolve begins at the top. I think now I've seen more and more CFOs, senior vice presidents of revenue cycle, in Becker's and other types of publications talk about how bad it's gotten with this payer denial issue. And so one of the things I didn't see in many organizations over the last 15 years is going all the way. And we think that there should be a firm resolution right from the top that says, look, if it's justifiable, you proceed until the end. You don't give up. All of that evidence-based medicine that Ryan showed towards the end of his talk, that's all well and good. But I can tell you for a fact, the payer's not going to look at it. The auditor's not going to look at it. You have to get it to a point of outside of the court of the payer's opinion, to a point where it's an impartial decision maker. Ryan mentioned, we have to make complaints, we have to make grievances. But again, part of it is getting serious about what they're doing to us today. Every managed care contract should be made available to everybody that is operationally responsible for overturning these unjustified denials. Those who are actually doing the appealing and dealing daily with the payers, there shouldn't be any exception to this. Now, we don't believe that you need to look at all of the rates, but certainly all the business terms you need to look at. So when I use the term payer content, people are going, huh? What's that mean? What is it? What are you talking about? Well, let's face it, there's a lot of payer content out there. The first one clearly is that contract. What's the contract between Aetna and your organization? Is it by market? Is it across the nation? Same thing with UHC. There are contract rules that have to be followed. The fact is, there's pitfalls in all of those contract rules that you blithely accept. And it goes down right to the provider manual. The provider manual details are killers. They just are. And so we think your managed care department ought to be tearing down that manual item by item by item by item and identifying, is this fair? Is it fair and equitable on both sides of the coin? And so if you see something that is unfair or something that should be there and isn't there, you should say something. So I don't believe that just managed care departments ought to do it. We all see things in provider manuals that, oh my gosh, we won't be able to match that requirement. It's got to go back to the contract. We think payer content, it definitely includes, as Ryan mentioned in some of his talks, statutory regulations and evidence-based guidelines. There is a standard of care within your community for serving those patients, right? It's there. And you have statutory regulations that protect providers, but also protect patients. And we'll talk about that. The payer policy bulletins. How often do they change them? How are they maintained? Where are they uploaded? Do I have rapid and quick access to the information that Ryan talked about? Do I have the patient's summary plan document? So what are the payer appeal timeframes? What are my open active disputes? Do I have appeal ready communication tools? And am I actually managing dispute resolution outside of the internal grievance process? If you intend to pursue and be persevering and go all the way, you're going to have an articulated, scripted dispute resolution and auto escalation process. And that's where you need to do it. The question is, what is it? Where is it located? And how do I use it? And so it's not as if you can just pick it up and do it. This is just one example of the way that we gather the information by payer. And so we also believe that you can take a look at all of that information that's up top there and say, look, under the payer policies and under payers, I need to know the timeframes. I need to know all the contacts. Who are my contractors that are associated with that payer? Let's face it, 5 years ago, there was Cotiviti, Equiclaim, and maybe one more who I don't remember. Today, there are 19 to 99 audit contractors. Evacor is a contractor. So let's face it, these contractors all want to throw their different rules and their different addresses and timeframes on you that you haven't agreed to. Do I have the contract readily available to my team that manages all this type of information? Whoops. Let me get forward here. Good. So this is an example to articulate, just get down into Humana's policies. And the way that we gather and determine which policies to make available to our teams is I take a look at what they've been denying that organization in the last quarter or the last 6 months and make sure that I can articulate a numerator and denominator. How many times did they, United Healthcare, go after sepsis? How many times did Humana go after bariatric surgery? So between your claims and between your remittance advices, you can identify those areas of risk, but only if you actively capture this information as it's being collected, meaning your audits, your audit findings. Another thing we talk often about within the contract is really making sure I understand the rules that we have to follow. They make the rules. So I need to get the right information to the right person and the right documentation at the right time. I want to streamline gathering all this information to fight back and to throw that tennis ball right back over the net. And so codifying those payer business rules, it's contract by contract. Very few clinicians have access to this. So we attend conferences all the time. And one of the largest complaints of our senior clinical leaders that we talk with is that we don't really have access to the managed care agreements. We don't understand that. Now I run into other clients and organizations that say, look, we've built out a matrix that shows me specifically what particular payers, what particular provisions, what particular time frames. And I'm like, great. Is the matrix built in? Is it automatic? Do you have it in an access database? Is it built out in Epic? Is it built out in Cerner? Is it built out in Meditech? Well, let's face it. With all due respect to, I think, the things that Meditech and Cerner, Oracle, Meditech, and Epic all have going, we don't think they are gathering this information, putting it all in one place. There are lots of organizations, so we're going to show some things that you can do that you can build out in your Epic system. If you are one of those believers in the Epic One or Epic First belief or the Cerner only belief, we get it. We understand you don't want to work in multiple systems, but we do think you need to have this information in your existing management system if that's the way you're going to go. You need to also present quickly the clinical business rules to everybody in the organization. Do they have access to the NCDs, LCDs when they're at that point of appeal, of fighting back? And I don't mean the point of care, but I mean the point of appeal. Do you give your specialist access to all the medical policies, the coverage policies, all those third-party guidelines sitting right there? That's what we believe they need access to when we get to it. Access to what understands when the payer is. Let me understand what information does Humana Gold Choice have? I have to understand, is it Medicare Part A modified? Do I have immediate access to their manual? Making sure I can put this information in a system, right? That says, hey, I know the process, I know their internal appeal and audit process, and I know the dispute resolution process. I've got that articulated and built into my management system so I can actually escalate quickly and do more appeals with fewer people at the same time. Let's face it, at the front end, UM, you're right there. You're in the middle of it. Who's the primary payer? What are the rules for inpatient? Do you have access to all the information necessary to be able to defend the medical judgment and decision-making of your clinical teams? Do you know the contract terms? Do you know if you're in network or not? And so all of this information needs to be provided to those specialists who are really working hard to identify and provide the very best defense argument for your organization. You have to give them information and access to the information to work. So see, these are some of the proactive strategies that we'd recommend. So exactly when you're building out your matrix, right? You know, you've got your top commercial payers, you've got your top Medicare Advantage payers. To us, Medicare Advantage, they are commercial. They're really trying to take it. They have to follow Medicare rules and Medicare clinicals, but they're still really dragging their feet about implementing all those changes that CMS has put forth for 2025, even 2024. So we think it's important to make sure that you identify what are the areas that I need to provide, who do I need to provide it to, right? I've got my coding professionals that are dealing with DRG validation audits. And so they're going to need access to different templates and access to different tools and access to really how many times did Humana challenge my bariatric surgery diagnosis or procedure, and making sure I have that. We understanding our appeal rights. What are the readmission guidelines? So access to all of this particular rulemaking is important for everybody. I'm going to spend a little bit more time talking about the provider manual, because to me, this is a very, very big one. If you read the manual and you recognize that there's language in there that would have an impact on whether or not it's fair and equitable to receive this denial, it really matters. And so you really can't accept language in the manual that is going to put you behind the 8 ball. That's where we actually have to add a contract clause that says, regarding this particular provision in the manual, this is what we've agreed to. So you have a contract that can essentially take whatever their national manual says, and you can actually modify if in fact you feel that it's not fair and reasonable for them to accept that language in that particular manual. It really affects denial and appeal management. And I think any well-negotiated agreement or contract is going to take all of those particular pieces of the manual into account and make sure that we go down checklist by checklist and determine and ensure that there's fairness on both sides, right? So you don't see certain things in manuals that you should see. If you don't see it, right? If it doesn't exist in the manual, you need to put it in your contract. Now, I'm well aware that, you know, there's about almost 320 people on this call, but very few of them are managed care negotiators. Very few of them are revenue cycle professionals. And so I put it upon you, the appeal nurses, the appeal physicians, the physician advisors, the other executives on the call, raise the roof. You have to make sure that managed care understands that they're a big part, and the managed care contract is a big part of managing and preventing denials moving forward. Medical necessity provisions. This is all very simple stuff. It's pretty important that we discuss this a little bit differently. What is the standard of care? We can't agree to language that allows the payer to control or determine what medically necessary services are. That's completely antithetical to the way we should be managing our patients' care. With all due respect to America's health insurance plans, they serve shareholders and we serve patients. And so it's a big deal, I think, not only to the folks that are on this call, but also to a lot of folks in your C-suite that, look, we get it. We need to be fighting for every dollar. Now that we're down to single-digit margins or less, we don't have the choice to be able to go after these guys. And so giving it all your best and not agreeing to language which would undermine the hospital's mission is quite important. Okay, this is language to avoid. So anytime you see this in a managed care manual, right, or in a provider manual, you can't necessarily agree to this. You have to go back to the contract and explain to them, this is how we're going to do our medical decision making, and there's no way of ands or buts. And so you have to stand up for what you believe in terms of whose right it is, and it's that patient-doctor relationship that we need to be harping on. It's the treating physician rule we need to be harping on. It's the fear of not getting the very best care or access to care that we need to be harping on. So we can't make sure that this information is not in your manual or in your contract. We can't agree to language that allows the payer to determine whether emergency services were required. That is the purview of the treating physician and the clinical team. So you can't accept language that permits that, although many manuals and many contracts include this exact type of information. if it says this, the health plan may determine that other similarly acute conditions are medical emergencies. You can't let them determine what's an emergency or not, okay? If the physician refers their patient to the emergency room, if the patient walks through the door, it's only up to you to do the triage and make sure that there's a life-threatening emergency or something not so life-threatening, but a serious health emergency. So you got to make sure that this language isn't necessarily included in your contract and that in the payer's determinations, emergency services required. That's not the purview of the managed care organization. All managed care contracts, and I think Ryan chatted about this briefly, 1/4 arithmetic and 3/4 operational administrative requirements. It's the responsibility of everybody on this call and your vendors, if you're using them, to make sure that we get these operational requirements put forth. We understand what needs to be done in order to submit a clean claim. We understand what needs to be done in order to code a claim correctly. We understand what needs to be done in order to document accurately and well. And so if we agree to these operational administrative requirements, we better follow them. Now for the managed care department, we talk about payer by payer strategies. And once again, I don't think there's many managed care organization or managed care hospital professionals on this call. So I would leave it to the clinical teams that are on the call, providing them information, suggestions, insights, right? That we can say, we need to be involved in the contracting process. And you need to be involved, managed care director, in all of our clinical operational meetings and calls with that payer. If we're having challenges in inpatient versus observation status, and we meet medical director to medical director, we certainly urge you to make sure the managed care department is on that call. And the same thing goes. If you've got a payer operational call, Mr. Managed Care Director, you should be involving utilization management and physician advisory. You should involve coding leaders and CDI with any operational call that has to do with audits, audit findings, or audit processes. So it's important that you go to the managed care department, everybody on this call, and say, hey, we want to be involved. We need to be involved. If you can treat the contract as a living document, part of it is that different people in different, let's call it different, I don't hesitate to use the term silos, but different silos have different responsibilities. Some organizations have a centralized appeal and audit management structure. Some have distributed governance for that, you know, at the facility level. But again, part of it is everybody's going to need something different and different information. So understanding what a contractor's time frame is for getting those, let's call it audit responses in or getting those medical records in is way different than dealing with the payer. So let's face it, the payer's got a third-party relationship with Cotiviti, with Equiclaim, with all of these other third-party auditors, third-party contractors, but they're not contracted with you. So we think there's some work to be done towards standardizing how you're dealing with audits. The devil is in the details. Everything about a managed care agreement really affects denials, audits, and really the whole process. And so we need to understand, how does the contract language affect my back-end denial and audit management process? What do I do on the front end to minimize receiving the denial on the back end? What can I do? What kind of prevention can I do? So we've really got to start our own discussion. I think the clinical side and the revenue cycle side have to start another discussion with managed care about any opportunity to change language that seems to be unfair to you or any other provider in the organization. Let's face it, the contracts are usually written in favor of the payers. They know what they're doing. They have lots of lawyers and lots of experience. What I find interesting is I still run into contracts that were written 20 years ago, but simply, right, amended year after year after year without ever adding in any protective language. So once again, you have to start the discussion with the payers. let's talk about audits briefly. So now this is really talking to that side of the shop that deals with clinical validation, coding reviews, and I'm going to bring this up today. What you see in one of your handouts, and this is going to sound kind of interesting, but it's a 15-year-old document called the RAC Statement of Work. What I find interesting is when we first put out RAC audit management software, we went through that statement of work tooth and nail. We really did. And what those require. And I find it really interesting that CMS or the government put together a very well structured audit program, right? There were timeframes. There were rules that the payers or the contractors had to follow. There were rules that providers had to follow. But they laid out, this is the number of audits. This is what you can audit. These are the timeframes. There is a discussion period. And so I think that's an excellent primer for anybody that says, oh, well, we don't have any audit language in our contracts. Go back and look at the statement of work and recognize that there are structural elements that are standardized and protective for both parties, not for just one. But clearly, if you don't have audit limits in your contracts, audit limits, I think you need to start to go to that, because even the government says, look, we're not going to put such an administrative burden on the provider that they can't meet their threshold of caring for the patient. That's in law. And so you have to determine directly with your payer, this is how many we're going to permit this year. And safeguards that say, if you have no findings up to this, you can't audit that any longer. Another big one for me is the recoupment thresholds, is making sure that the recoupment rules aren't set by the payer and they aren't set by the payer's contractor. They're taking money that you've already been paid. And so I think you need to set the standards and the thresholds and the timeline for any recoupment action. I don't think it's quite fair that you've received a finding, you're defending yourself, you start the audit process, but within 30 days, they pull the money back. We're like, no. What's fair and reasonable is that we get to go through our appeal process, very similar to what CMS did when they set up the RACs. Discussion period, level 1, level 2. If you are still upheld at the end of level 2, then they recoup. But we're talking, that was almost 240 days out. It wasn't 30 days out. I don't believe that payers should be permitted to take any money back until that appeal process is completed. Include the appeal process in your language. Standardize it. If you don't have a portal, you need one. So them requesting additional information, them saying, we want you to print 5,000 pages and send to it so we can scan it in, as opposed to saying, no, there's other ways that we can do this. Audit limits matter because we know that we can get dumped on. So I have certain clients that send us 400 to 500 a month because one large payer has dumped so much on them. So audit limits help you streamline and really make it a little bit more predictable what those reserves need to be based on your overturn rates and your other systems. So it's not a hypothetical situation. This is a reality. We have to put limits into their ability to look at our information. Audit limits, we can really, sometimes we get arbitrary payer audits. They don't know why they're auditing it, but there needs to be a specific rule set as to why they're looking at those types of claims. If it has to do with claim size, if it has to do with a specific physician group, if it has to do with a specific DRG, discharge DRG, great. Just make sure you identify what it is. What are the boundaries on the scope, frequency, and timelines of audits? And really need to make sure that we protect our revenues going forward. I believe this. If they know that you insist on reasonable terms, they're more likely to respect your overall provisions. Now, I do a laugh out loud here because I'm not sure they respect our contract provisions at all. But the truth of the matter is that we need to get this information out in front of them. It's fair and reasonable to expect, if in fact we have 45 days to appeal, that when we submit the appeal, they have 45 days to respond. And if they don't respond, the audit's over. So part of it is saying what's good for them is supposed to be good for you as well. Sometimes lawyers in our office call it quid pro quo. What's good for you is good for me. And it's really about being fair and reasonable. Ryan talked a little bit about, you know, the unfair business practice. We think that's an obvious one in a lot of these denials, that they're really being a bit unfair in how they're providing the information to us. Taking command of your contracts. So audit limits are an absolute necessity. So we have to ensure that we are protecting the hospital's bottom line. We have to own that. And so we don't believe that managed care should be a silo left out from the clinical and the revenue cycle management of disputes and challenges. Entitled rights, right? So we talked about this over the years to many organizations. I'd like to thank Eddie Hugh from University of North Carolina and Brian Moore from Atrium. They really brought this up in our discussions last year that, look, Medicare Advantage, we've done everything we can to make sure that the payers are following the Medicare Advantage rules. And that right to be a Part C contractor is important. However, if you haven't begun to incorporate or include the patient's rights of appeal, you're missing the boat. You really lose leverage there. And so dispute resolution, you really should have dispute resolution processes in every agreement, and it should be utilized indiscriminately. That's enforcing your entitled rights. And so if you're not using dispute resolution, if they believe you won't go to dispute resolution, they're going to target you. There's lots of different systems that you can expect, and external resources as a standard part of that appeal process. So I'm not saying it's got to be our system, and I'm not saying it's got to be Epic, but you have to do something to centralize all of that appeal management functionality in a system-wide or enterprise-wide approach. This is a no-brainer for us. We really recommend a full court press. And for those of you that don't play basketball, it's a tough thing to do. We think you need to understand and harness your understanding and knowledge of the contracts and incorporate contract language, legal language, and obviously the clinical facts that help you win that case. We make sure that you are understanding what are your internal review rights, what are your external review rights, what's independent review, making sure that's all in there. E-communication, we haven't talked about it, but it's a big thing now. So everybody knows that United Healthcare only accepts appeals online, right? And now they're going to give you their decision online. You have to go into a portal. What keeps us from creating a portal that also helps standardize it? How we receive the information, how it's interpreted, and how it's assigned. And so building your own portal to gather information, to gather audit detail, denials, all of that in one spot makes it really, really important. And then believing, really, what is your scripted process? How are you automating payer escalation? Are you automating expedited reviews? Are you incorporating member rights and member appeals? So we believe that if in fact the member at the consent to treat signs the fact that you can appeal on their behalf, you have the ability to send not only provider appeal, but also a member appeal. However, recognize they're going to different places, different timeframes, and that member has additional rights that you do not have as a provider under a contracted commercial agreement. I think the last slide before we get to the closing and some questions and answers is really, I believe you got to go up to the C-suite level and say, look, because everything points to not just what's going on, all the chaos that's going on right now from this United Healthcare debacle and this terrible thing, My fear is that once it leaves the news cycle, that people will forget about hospitals and denials again, and patients who aren't being provided access to care. So we think that CFOs and the CEOs are now getting it, right? And so we have to keep the momentum going with them. The marching orders really for managed care have to come from the C-suite. The managed care director, he's not going to want you calling the employer. No way. He doesn't want you calling, the payer's legal department. They don't want that. They want to maintain the relationship. We'd like to get paid. And I think it's important that if you're going to serve your hospitals in this area and serve your communities in this area, you need some help from the C-suite. Okay. All right. So now I'm going to open up to question and answers. Before we do that, I want to make sure that you know that we've included in this presentation a survey at the end. Now, we've done this at conferences for many years, but if you just take the time to answer that survey and complete it, that will, from all of the people that did complete that survey, we will donate a television and Xbox to the Children's Hospital or children's charity of your choice. It's something we love to do. We support children's charities here, and a charity here we call Santa's Helpers in Maryland. So consider doing that. So I'll open the floor, and maybe start with questions. If there are in fact questions in the chat, Eric, can you take a look at that? Maybe throw them to Ryan and us, or again, we're okay with, Eric, how many are in the chat that you're aware of?
Looking at it, it doesn't look like we've gotten anything yet. So
Okay, good.
If you want to, leave that open-ended for a minute or two, we can do that.
We can do that. And then we can also, how do you if somebody raises their hand, how do you turn off the audio or turn off so that they can actually ask a question? Is that possible?
I don't know that we have that option in this sharing setting.
Oh, okay. Okay. All right. Huh. Okay, so if anybody's, we'll wait a minute or two. If anybody's got a question for Ryan or for myself, or frankly, suggestions, things that work, please feel free to put them in the chat. But if you put it in the chat, I'm going to let the community know.
There is one question in the questions panel about a handout. Is there a handout with a language that you used for the appeals?
Well, as Ryan was going through that slide, that's what was coming to my mind. We do have language. We didn't present it all at this particular, so we presented, but we will provide examples of language for each of the bullet points that Ryan put out there to all the attendees that requested.
Yeah, it would have turned my slides into a lot more slides. But yes, I tried to give some of that language, but we can certainly provide examples of that. Yeah.
So what we'll do is in the post webinar email, we'll let you know where you can access that, either on the PayerWatch website or the Adam website. And that way you can all at your leisure go in and grab it. Okay. Any more questions in that chat, Eric? No?
There are. I'm trying to get to them because my.
Oh, sure, that's fine.
Let's see. What is a good legal language for payers denying inpatient level of care and say this is, and my screen is cutting it off. Saying that it's OBS level. And the appeal's been submitted with a medical necessity review and still denied by their own doc.
Oh, by the payer's doctor.
Yes.
Right. So a lot of times it really, the source of the admission is an important consideration, obviously. We did talk earlier about admitting through the ED. and the need for stabilizing the patient. And if the physician in their particular judgment believes if it's Advantage or traditional Medicare, that patient's going to make it through 2 midnights, they have to document that, and they have to document their complex care plan. If they've not done that, sometimes it's hard to beat that one. However, it's really up to the treating physician rule, and we can argue that, but part of it is making sure that we incorporate other clinically based evidence that supports that physician's decision to make that patient an inpatient. It could be average length of stay, it could be complications and comorbidities, but as far as the legal language that we're going to incorporate with that, it's going to come down to that treating physician rule that we would typically put out there.
Yeah, and one thing I would just kind of add to that generically is, you know, I believe there's more, but there's 3 key parts to me an effective appeal is you have to have legal research and reference, right? So no matter what legal argument you're making, you have to make it and cite what you're referencing to that. The second is you have to have the clinical research and reference. So you have to have why I am clinically supporting this document. And the last is really those evidence-based models. But the reason I focused on legal today is I think it's an area that's often overlooked. I think we often make a decent clinical argument, but that legal argument I think is important. And I think in the case of medical necessity, we have to make the clinical argument, and we have to illustrate that the care team acted with appropriate care and diligence to mitigate whatever it was that this patient was presenting with and continued to present with in that continuum of care. And so, yes, I think the legal argument is that a physician and clinical care team are based on your statutes or federal statutes acted appropriately, but that has to be supported again with the clinical argument as well.
Oh yeah, the clinical argument has to be there before the legal argument's going to do any good anyway. And as I said to Ryan before, even evidence-based guidelines, the payers don't give a hoot. It's only when you get outside of that court of the payer's opinion, those evidence-based guidelines mean something to independent reviewers and to administrative law judges. So
yeah, and I think, you know, Brian and I were talking the other day, and he brought this up of the putting all that together, the evidence-based models, the clinical research and reference, and the legal research and reference will win you more first appeals. Promise, it'll win you more first appeals, but it's not going to win all of them. And one of the things that Brian and I talked about is what this does, though, is it sets the foundation that if I follow this to the end, which we have to be willing to do, I will win this thing based on the argument I've made. And then it gives me more kind of macro argument from a managed care department to say a precedent has now been set, and we don't want to see these anymore.
Yeah, I'm the first one to tell you that for many, many years, I was disillusioned by how many hospitals would stop at the end of the internal grievance process. And we knew, hey, when we took things to the ALJ and the RAC, we won 80% of our cases, 80%, when the payer wasn't or the MAC wasn't making the decision, right? The RAC wasn't making the decision. Once the ALJ got a hold of it, they look at all the evidence, a preponderance of evidence presented in front of them, and we won 80% of our cases. We don't understand why, now that the commercial payers have piggybacked off of that and hired and created a whole new cottage industry of audit contractors, why don't we follow that strategy again? Take it all the way. Don't let the payer make the final decision. So, Eric, any more questions in there?
Yeah, here's another good one. What is your best advice for gaining the resolve of the C-suite? Or maybe the buy-in of the C-suite, if we can read into that some.
I'm probably more equipped because I've sat in the chair of a revenue cycle leader for you know, half of my career. Similar to the governance I talked about is I think you have to bring data. You have to say, And again, I think that's a co-collaboration. It just isn't revenue cycle bringing it. I think it's a collaboration with someone in that administrative suite, probably the CFO's support team, that's saying we have gathered data through reasonable estimations of improvement. We think there is this, and what we're asking for is something that does in fact have an ROI. Now, do you trust me? And it may be they don't, because I would argue that the CFO role inside of healthcare has been a little bit minimized to not necessarily what a CFO might be in another organization, but a accountant who's been mandated, just as we all have, to manage cost. And we should be doing that. We should all be good stewards of our resources. But to shorten my answer, I would say you have to bring data, and you have to say, I've made assumptions and I'm willing to put my skin in the game that there's an ROI to this. Yeah. And that data has to be supported, not just by you, but probably by finance as well.
So it's important, as I said, over the last year, I've just started to see lots of CFOs, Michael Dowling, Dan Marcet, others, quoted about how they can't take this denial situation anymore. In other words, the time is right. I think if you talk to your CEOs and CFOs now and really talk about what a serious problem it's becoming, now is the time to talk to them. Because we're in the news cycle now, right? So denials and audits and unfair situations where patients don't have access to care, it's not often in the news, but it is now, okay? It's in the national news. If you're going to approach your C-suite, now's the time to do it, and saying, we have a plan. We think we can do better at this. And we think in order for the hospital to survive, this is a big part of what we need you to get behind. So use the passion of the moment, right, to make a pitch. You can do it. I know you can. Eric?
We do have a number of other questions here if we want to keep rolling through them. I know we will send out answers to any that we don't get to all the attendees, but if you got time, Brian, I can shoot it, give you a couple more.
Yeah, we still got 245 people on, so I know we're at the end of our time here, but certainly if you pick out an interesting one for Ryan or myself, and as Eric said, we'll continue to answer these and get the questions and the answers out to all the attendees and all those who didn't attend.
So here's a good one maybe to end with. Any thoughts on denials sent after an AI review?
By the payer or by?
By the payer. I assume by the payer is what we mean.
Yeah.
I think that encompasses a lot of them these days, but go ahead, Brian.
Well, I think that Medicare and CMS have come out with some rules and some regs about that in terms of the utilization of, now maybe it's a proposed rule, right? But right now, I think that we are expecting you to rely on the clinical knowledge of your teams, not on AI to read through the chart. And so we think you have to defend an AI denial, right? The same way you're defending a non-AI denial. Go after it. What are the clinical facts? What's your legal argument to support the patient and the right to be paid? And so we're not saying you should do anything special. If you know it was an AI generated and it's wrong, because we've been testing it and we push it really, really hard. And unfortunately, occasionally it gets wrong what we expected in terms of the output. Maybe that has to do with our query, but I wouldn't fight an AI denial with an AI appeal ever, if that's part of the question. So.
Yeah, I mean, I think leaning into the idea that the payer, again, by both state and federal law, has to provide a reasonable and accurate explanation of the basis for their denial. I think that is an argument you can make. I do worry, and I've expressed that. I think I think as healthcare operators, health system hospital operators, you have to invest in AI because of just the efficiencies that come with it. But AI talking to AI is I worry, the natural progression of this thing is where we're just going to have bots talking to bots and nothing's ever going to really get accomplished. And so, it is why, at DRG, we're really focused on this content enablement, because AI certainly speaks to the efficiency, the gains that I think we're all challenged and strapped with every day, is how do I get out more work with the same amount of resources? And so AI can help with some of that. And the insurance companies have obviously figured that out as well. But to Brian's point, AI fighting with AI is almost a perpetual loop. And so at some point you do have to make an argument and support it with evidence that says, I'm going to stop this loop and we're going to take this to a different argument as opposed to bots talking to bots.
Yeah, so there's language in federal statutes and some states that talk about making sure that, for example, at CMS, if they're challenging a clinical diagnosis, it must be reviewed by a clinician. So that audit review has to be done by someone who's an RN or above to get a denial specifically from CMS. For a DRG downgrade or a DRG validation challenge. And so even in your contract, and that's one area that I really wish I had that slide, I wanted to present it, is that even in your contract, you can require that anybody doing medical review on behalf of whether it's the payer or a contractor be certified, right? So whether they're board certified physicians or they're an RN, certified with a medical experience with medical review, because when you look at that RAC statement of work, the government told the RAC contractors, you must hire medical reviewers with at least 3 years of experience. They didn't say you can use AI. They were very specific about who was going to do the clinical reviews on behalf of the government to send out as a part of these RAC audits. So you can incorporate language like that in your agreements. And if they don't like that language, tough. You want clinicians making the decisions, not robots. Well, I think, again, so I'd like to wish everybody very happy holiday, Merry Christmas, Happy New Year. Feel free to pre-register for the next webinar, which is really about denial data and how to use it to improve denial outcomes. And so I want to thank everybody for attending, and go out and support your communities. I think the fight is up to us, right? The fight is definitely up to us, but persevere, be strong, and let's go get them. Thanks everybody for attending.
Thank you all. Happy holidays.
Happy holidays.